Hello, everybody. It's so great to see you all. Welcome to today's session, The COVID Generation at Age 5, Implications for Health, Development, and Parenting. I'm Ira Hillman. I help lead the Early Relational Health Funders community, and it's my pleasure to welcome you on behalf of the Early Relational Health Funders community and the Early Childhood Funders Collaborative, who is co-hosting this session with us. We are recording today's session, so just be aware of that if you are on camera. But also be aware that if you need to step away, you'll be able to view the recording. More about that in a little bit. A couple housekeeping notes. If you would please make sure that the name that appears in your Zoom box is the name by which you like to be called, and also include the name of your organization, your foundation. We'd love to make sure that everybody sort of knows who's here. And who's speaking and who's asking questions. Also, I encourage you to get to know each other a little bit in the chat by answering the prompt that we had on the intro slide. Who brought you unexpected joy in the past week, and what was it? I had a friend visit who I hadn't seen in over a year, and she happened to pop in for a surprise visit on Memorial Day, and we got a chance to catch up for a few hours. So that was my unexpected joy, but hopefully you had some unexpected joy this week as well. We're here today, it's May 2025, and I think we could all take ourselves back to 5 years and 2 months and a couple weeks ago to early mid-March of 2020, when the COVID pandemic really came into our lives. And we were all really thinking about health, child health, early childhood development, maternal health. What was this going to mean for babies, for parents? And what about their relationship? What would the virus do to that? What would the stress of the pandemic do to that? And so we're going to talk about what we've learned as we look back on the development of babies and moms in that period of time. But this research that you're going to hear about today also provided a very unique opportunity to study parent-child relationships among a cohort of a larger size than anything that had been done before and over a period of time that had not been done before. So the insights that we've got around relational health are quite extraordinary. Now, here at Einhorn Collaborative, the foundation where I work, we're particularly interested in early relational health because we believe that those strong, positive, and nurturing relationships early in life help babies' brains and bodies learn how to show up with mutuality and reciprocity, meaning that later on, as young adults and older adults, they show up with mutuality and reciprocity with their others in the country and the rest of the world. But the rest of you are here for maybe a variety of other reasons. You also see early relational health as a means to an end. But for you, maybe that's child health later in life. Perhaps it's the literature you've read about the importance of early relational health to social emotional development, or helping children be able to sit still in the classroom and be ready to enter kindergarten. Perhaps you're thinking about maternal health and the relationship with this, and that if we focus on the relationship, we can help improve maternal mental health. Whatever brings you here today, I hope you will leave with at least one valuable aha, or even maybe leave with a question that you're still asking yourself around your strategy and around something that you might even share with some of your grantees. Our plan for today is that we're going to begin with a conversation between our moderator, Edith Bracho-Sanchez, and Dr. Dani Dumitriu. And then Dani's going to bring in other members of her team into the conversation to tell you more about the research findings. And then around the top of the hour, we should wrap up our conversation and have time for questions and answers. So while you are hopefully following Catherine Monk's lead and putting things in the chat about your unexpected joys, I hope that as we continue through the conversation and you hear things that you're saying, "Ooh, I want to know more about that," or I don't know if I caught that, use the chat. I'll be monitoring that, and we'll bring those questions into the conversation about an hour from now. We are not going to be doing very extensive introductions of each of the speakers because we're going to share with you instead the bios, which will be something else that you will be able to find in the chat. So I'm going to put a link in the chat now. So if you want to know a little bit more about each of our speakers, I encourage you to have that open or reference it later. Today's event is part of the series of events that we offer through the Early Relational Health Funders community. And if you're not already a part of it, well, now you are, because you've joined us today. And so there's no cost to be a part of the community. We're just trying to help funders in this space learn more and connect with one another. And one of the ways we do that is a monthly newsletter that goes out at the end of each month. And so the newsletter will go out tomorrow and will include a link to all the resources, slides, and recording from today's session. So feel free to find that all there. And also our co-hosts of the Early Childhood Funders Collaborative will post everything on the event webpage on their website. So you'll be able to find all of that. Now I'm going to turn us over. I'm going to bring into the conversation. Let me do that. Here we are. So I'd love to say I'm looking now at an not an older friend, a friend I've had for longer, and a friend that I've had more recently, right? Let's talk about it that way. So I'm very sensitive these days to saying the phrase older. Dr. Dani Dumitriu and I have had the pleasure of working together over the last several years, where she is the leader of the Center for Early Relational Health at Columbia University, and has been part of a collaboration that we've helped support between Columbia University, Reach Out and Read, and Nurture Connection. And I'm sure you'll hear more about that and some of the research from Dani as she gets in conversation. And I've more recently had the pleasure to meet Edith, who I know is an amazing pediatrician, and so also a person who lived through the pandemic herself and is thinking about this as a perspective of a family member, but also the host of the American Academy of Pediatrics Healthy Children podcast. So if there's anyone who I know is going to do a great job of hosting today with warmth and great knowledge, I know Edith will help us do that. And so I'm happy to pass it over to you, Edith, to begin the conversation with Dani, and I'll see you all in a little bit.
Thank you, Ira. Yeah, thank you so much, Ira. And I'll just say, a mama who delivered during the pandemic. So I am showing up today, as both a pediatrician, a colleague who has so much admiration and respect for your work, and a mama who delivered a pandemic. So let's get right to it, Dani. Sure. Take us back to the beginning. How did you start studying COVID-19 and moms and babies?
Yeah, especially how did I start studying that as a mouse neurocircuit person, right? I was cutting mouse brains right up until the pandemic. But I started because I was freshly into my second year at Columbia University. And while I was mostly doing research, I was also a physician in the newborn unit. And all of a sudden, I was thrown into being a frontline physician in the first nursery in the country to host a laboring and delivering mom who had COVID. And so, this was a time of tremendous fear, tremendous amount of questions. And we were also, because we were at the forefront of this, in charge of coming up with the protocols for the rest of the country, really. So, starting with a little anecdote, one day, maybe second week of March, I walked into the nursery. I had become the designated COVID attending for all the babies born to COVID positive moms. And I walked in and there was a lot of commotion among the nurses talking about a particular mom. And so I turned to them, I said, "Oh my gosh, what is wrong?" I thought perhaps she was, really, really sick. And it turned out that this mom wasn't sick. She did have COVID, but she had very mild symptoms. But she was so afraid of holding her baby, of having her baby in her room, didn't want to breastfeed because she was terrified of giving the baby COVID. And so, I spent the first hour of my day that day just talking to her. She had planned to have the baby sent to a family member for 2 weeks after delivery, right? And by the end of that hour, that baby was there on the breast of this mom, breastfeeding. They went home together. And so, that really galvanized me into thinking, gosh, we have to study this and we have to study it really quickly. And the first question, of course, was the question of vertical transmission, or does the virus go from mom to baby, either prenatally, so while mom is pregnant, or postnatally, right? So the question of vertical transmission is what we tackled first. This is when science meets serendipity. It wasn't actually the plan to not separate moms and babies, because throughout most of the country, there was separation between moms and babies, and actually most of the world. But we didn't actually have space here in Colombia. And so we had to figure out ways how to cohort them. And, we did use appropriate precautions. Mom wore masks. They had to wash their hands when they were eating and, having to take off their mask. The baby was in the incubator. But this allowed us to very rapidly study, was it safe to keep moms and babies together? And so we put together this paper in 14 days to the date, and we showed that the first 101 babies born to COVID positive moms at our hospital did not have any risk of vertical transmission. And this data contributed to ending worldwide separation by was picked up by CDC and other organizations and contributed to that.
Gosh. And I'm listening to that story, and I think we can all relate, right? Those of us who are parents and not, to not wanting to harm your baby in any way, but yet in those early moments of motherhood, of parenthood, you also really want to be with your baby. So such important research, and not surprised knowing you, as I said, as a colleague, that you put this together so quickly, but still so impressive. Now, I'm curious to learn how you went from studying vertical transmission and this very real experiences you were going through in the front line to then creating the combo study. How did that happen?
Right. So that happened pretty quickly too. As we were studying newborns, and in particular looking for whether or not these newborns were at risk for getting sick, I learned that my colleague, Catherine Monk, had simultaneously, equally rapidly, started a study to understand the effects on pregnant women and their maternal mental health. And so Catherine and I got together really quickly, and by summer of 2020, we had joined forces and become combo. And I have to say that this was in part about camaraderie, but also in large part, and as Catherine will tell you a little bit too, about this, tremendous opportunity to go across disciplines and learn from each other. And underscoring how important that is, not just for clinical care, this also makes for really good science. Catherine and I, along with our colleague Rachel Marsh in psychiatry, actually wrote a grant within the span of about 4 weeks in that summer. So among all the other things that we were doing, and that got funded on the first submission, just speaking to how important and elevating this kind of cross-disciplinary work can be. And so I'll let Catherine tell us a little bit more about her side, the maternal side.
Still making that mistake years after the pandemic, and we learned to use Zoom. Good afternoon, and it's so nice to be part of this conversation. And I really want to start with emphasizing, as Dani already has, but just how, if you will, joined at the hip in some ways, we are really of the same mindset of how important it is to keep mother and baby and the family context in mind. So always this dyadic perspective. And the interdisciplinary work, OBGYN to peds, really supports that. And I'd like to, share an anecdote that really, for me, captures and still is in my mind of this close collaboration. It was, and really the interdisciplinary work. It was, at some point during the pandemic, I actually can't quite locate it now, but I was seeing a woman throughout her pregnancy who was really, as so many were, really struggling with the isolation, and also had a medically complicated pregnancy from childhood cancer. And when she delivered a healthy baby and she was healthy postpartum, I went to visit her in the hospital to really talk about how she was doing and share with her the joy. And there I am with my mask on. We all have our masks on, and lo and behold, I turn as another doctor enters the room, and it took us a minute to recognize each other with our masks on, but there was Dani, and we gave each other such big hugs. We've been seeing each other so much on Zoom, and it was just a great moment for me, but also really importantly for this patient, because she could feel the collaboration, the close collaboration between our two departments and our disciplines, and I think really felt taken care of in that sense. But this story I'm telling you, this brief story, also really, I think, underscores an important part of our work. I think so many of us have in our minds, we've either felt it or we've heard it from friends or colleagues, and I hear it from patients and research participants. Postpartum, the birthing person can really feel like they're the candy wrapper and they get tossed aside. There's attention to them in pregnancy, but then they feel tossed aside. And I think this example with both Dani and I at the bedside, and then throughout this time together, as you're going to hear about the research, we are keeping the pregnant and postpartum person really in mind. She still matters. The birthing person still matters postpartum. And again, we have this dyadic perspective. So let me say a bit more. I have this focus. I'm a clinical psychologist, and my research very much focuses on mental health. And the other part of my research that has been really relevant to our collaboration is I work in the area of prenatal programming, or the developmental origins of health and disease, which is really that not only from a psychological representation, but also from the biological connection between the birthing person and the future child, what that pregnant person is going through can affect brain behavior development before birth. And this awareness, of course, it's been out there for several decades now. Tons of research supporting this prenatal programming, but mental health can impact the baby before birth. So parenting begins before birth. The dyad is there before birth. This got us, along with the wonderful chair of OBGYN at Columbia, Dr. Mary Dalton, to start a mental health, an integrated mental health program within obstetrics and gynecology, within our Center for the Transition to Parenthood at Columbia in August of 2019. So that was a rather fortuitous time because, of course, 6 months later, there was such tremendous need for mental health services, and frankly, really people acknowledging that they really needed support. And again, a vivid memory from that time, Dani already described, the fear and anxiety that we were all experiencing. I remember doing a telehealth session with a patient and hearing the sirens outside of my window, but then they were also radiating through the telehealth visit. And, both of us, really, all of us, just ensconced in this time of fear and anxiety. The up end of this, what people often call the silver lining, is the pandemic got us to a place where mental health is, for the most part, delivered through telehealth now very effectively. And so briefly, we have a thriving integrated mental health service now. We're up to 14 clinicians. We get over 40 referrals a week, and we take insurance. So the last point I want to make, actually, I want to tell you one more point. I was going to make my policy point because that is very important to me, but also to say what's driving the policy is because we're doing research. Dani and I and Andrea Navallet on her team, whom you'll hear from, really looking at outcomes with our integrated mental health service. We have over 60% uptake of the offer of mental health service. It's accessible to people. We take insurance. Typically, it's about 35% of people who actually get treatment who need it. So dramatic increase. And we're using this data, we're using this research to contribute to changing policy. And we have a very small grant right now from the Aspen Institute in order to hold a World Cafe meeting in March in DC, cross-sector, across the aisle, really taking on the issues largely driven by insurance companies of why mental health is so inaccessible, really focused on the perinatal period. So it's just such a pleasure to work with Dani and her team and to be part of this conversation. Thank you.
Thank you so much, Catherine. And really, this is a win-win-win, right? It's a win for me personally because it's been so much fun, doing the science together, and we've become really, really close friends. It's a win for science because it's just generates better science, but it's ultimately, most importantly, a win for the patients.
Yeah, and I mean, such an important collaboration. We know that moms and babies don't exist in a vacuum. I'm curious what came next, Dani.
Yeah. So, after vertical transmission, the next thing that we started worrying about was the neurodevelopment of these babies. They did look normal, for the most part. I mean, for all the parts in the nursery. But, just to contextualize this period of time for, me as a newborn doc, we were just coming out of the Zika epidemic, right? The peak of that was around 2015, 2016. And I still, vividly remember in 2019, my first year in the nursery, having cared for a patient who had been exposed to Zika in utero, and how just devastating it was to that family, right? So, we felt a real obligation to put this data together and to put it really quickly, right? So focusing on the babies born in 2020, so the early pandemic time, we very rapidly mobilized to put together a parent report study. So here we use the Ages and Stages questionnaire, which I'm sure you're using in your clinic all the time, because it's both a research tool and a clinical tool. And it asks questions like, does a baby smile? Does the baby gurgle? Does the baby reach for toys? And it's just a nice tool to get a sense of the overall development of these babies. And so, we put this data together super quickly, and then my team showed it to me, and Ira is going to now show it to you. And here, just to orient you, what you're seeing is every blue dot is the neurodevelopment of a baby who was not exposed to COVID in utero. So mom did not have COVID. Every red dot is a baby whose mom did have COVID during pregnancy. And what you can see, in this fairly high sample size study for being put together so rapidly, 255 babies total, is that there was absolutely no difference between their neurodevelopment, right? At 6 months. And, I have to tell you that when my team showed me this, I said, go back and reanalyze, because I don't believe this. There's got to be at least a very subtle difference. But no matter how we looked at it, whether we looked just by boys versus girls, socioeconomic status, we really did not find anything.
Yeah. And I'm struck again, listening to you, at the readiness of your team, right? Like, you had the expertise, you had, the insights from prior epidemics like Zika that you're referring to, and you were as ready as a researcher can be when the COVID-19 pandemic happened, right? Now, I am curious though, and the data that you're showing us, it's from this questionnaire that you referenced. I'm wondering, how does the data that moms report, right? This is reports from what moms are observing, relate to what you can measure when you bring the babies in and you actually observe them yourself.
Right. You're touching on the cornerstone question in science. Do you do a parent report, or do you do an observational measure, right? And, these things are not, one is good and one is bad. They're complementary to each other. But you are right that parent report also holds other information, right? It holds the mom's lens. And so things like maternal mental health will influence that lens, right? And so, the gold standard in terms of neurodevelopmental assessments is, of course, to bring the child in and to assess the child, either as a clinician or as a researcher. But it was fall of 2020, and we didn't feel that it was a good idea. So instead, we very rapidly innovated, and we actually got together with teams of behavioral pediatricians who helped us develop these assessments over Zoom. And we entered a next phase of very rapid science. So we expanded the sample size. So we conducted a study on 407 babies that we had fully behaviorally assessed over Zoom, 45-minute sessions. We also expanded geographically into Utah and Alabama. And we expanded the time window. So we went babies born 2020 and 2021. Again, the main question being, does maternal COVID during pregnancy have an effect on neurodevelopment? And as you will see when Ira puts the next graph up, and here to orient you again, every blue dot is a child who did not have exposure in utero, and every red dot is a child who did. To our complete surprise and amazement, there was once again absolutely no difference. And I promise you, I went back to my team, this time too, and I said, there's no way, there's gotta be, these kinds of sample sizes, some slight difference, but we did not find it.
Yeah. So impressive. I'm gonna say this is like so crazy, but sometimes I like have problems with my own patients, like getting them to pick up the phone, communicating with them about their results and different things. And I'm listening to you talk about how quickly you recruited hundreds and hundreds of babies. And I'm just like, my goodness, your team got to work, Dani, your team got to work. Now, talking about these results, they were picked up by so many media outlets. I wrote it down because I didn't want to forget. It was in the top 5% of all research outputs scored by Omnitric. It was cited in 360 news stories, 222 outlets around the world. We're not used to hearing good news, right? Because in many ways, these results are good news, right? These babies were not affected when they were infected or exposed to COVID-19, I should say, exposed, right? So why do you think the good news was picked up and talked about so much?
Well, sadly, it wasn't the good news that was picked up. Good news unfortunately makes you neither famous nor gets you a lot of grant funding. So, unfortunately, it was not that.
Yes.
In that first study, we were extraordinarily lucky that one of the team members, the team lead, Dr. Lauren Shuffrey, had started a study at Columbia using the ASQ, so the same parent report tool that we were using, and had gathered data on 62 babies born prior to the pandemic, but very similar sociodemographic population, right? So babies born in our hospital system. She was studying something totally different, but we were able to compare those babies that were born in the 3 years prior to the pandemic to our 255 babies born during the pandemic. And as you will see in the next graph, this time we did see a significant difference. Now, here, just to orient you to the slide, everything in purple is a baby born during the pandemic. So here I've collapsed for you the blue and red dots because there wasn't a difference by virus. And now we're comparing to a historical cohort of babies born prior to the pandemic in gray. And what you can see is that the babies born during the pandemic had slightly lower motor skills and slightly lower personal social skills. Now, these aren't huge differences. They're a couple of points on the scale, that goes up to 60. But all of a sudden, now we were going from a ceiling of 15% of possible babies being affected, because approximately 15% of pregnant women got COVID in 2020, to a ceiling of 100% of babies potentially being affected, right? By just being born or being in utero during the pandemic. And that, of course, from a public health perspective, is a huge number.
Of course. Now, I do want to make sure that I am following correctly here, Dani, because before you told us that the virus itself did not have an effect on neurodevelopmental outcomes, right? Or neurodevelopment itself. But now you're telling us that being born during pandemic, that when you zoom out and take into account pandemic as a whole,
yes,
did have an effect. I'm wondering, and I think this is sort of the natural question that people watching may be wondering as well, do you think it was related to stress, and specifically to maternal stress?
Yeah, no. So unfortunately, in that first study, we did not have the opportunity to measure that. But yes, we do believe that that is the mechanism by which we're seeing this effect. And in fact, we do have another study that was published, not on neurodevelopment, but on infant temperament, which is related. So thinking of things like fussiness, which is not actually just annoying to parents, but can bode problems with development later on. There we did, again, we did not find a correlation with, mom having COVID. So there was no difference between fussiness of babies with and without COVID exposure. But we did see a very significant association with maternal stress, and in particular, their COVID-related stress. So these were questions related to how much stress they were experiencing during the COVID pandemic. And indeed, that correlated. So, just thinking of both sides and this dyadic approach, and that something in the relationship was transferring from mom to baby, because it wasn't the baby's stress, right? Like 6-month-olds were not really stressed by lockdown. So the mechanism by which we think that this is happening is to this transference of the stress from mom to baby.
Yeah, fascinating. Dani, I'm hearing virus and I'm hearing stress. And I'm thinking of development, and my pediatrician and mom brain is going toward thinking about autism, because that is a question that I'm asked in my practice all the time. So I'm curious what your team found. Does being exposed to COVID-19 in utero increase the risk of developing autism later?
Yeah, no, this has been something that we've been worried about the whole time. And
Yeah.
I have to first say that we are a little too early in the pandemic to really know if it actually increases the prevalence of
Fair.
autism.
Yeah.
The diagnoses, for those of you who might not know, they tend to show up at somewhere around 4, 5, 6, 7 years of age. We can't really diagnose too much earlier. But we can screen for autism risk, and we can start that at 18 months using tools like the MCHAT. And so one of our most recent papers actually was the world's first report on MCHAT scores of children born during the pandemic. And this was a really impressive piece of science, because we were able to use both clinical scores of MCHATs, because we here, I'm sure you're doing some MCHATs in your clinic,
Of course.
as well as research MCHATs. And we were able, in both the clinical and the research side, look at both the question of pre-pandemic to pandemic differences and the question of in utero exposure to the virus versus not. So it was a really big study. It involved over 2,000 babies. And the answer resoundingly was no difference. And so, more good news, more bad news for my funding opportunities, but more good news for the world that we, have been very happy to be able to generate super quickly.
Yeah, no, amazing. And I remember this one also got picked up in media, because I think a lot of, again, parents and the general public were wondering about this. So incredibly good news. And I think so far, Dani, everything that you tell us is pretty good. It's pretty compelling, right? It's good news. Now, I think the natural question is, will you continue to study this cohort?
Well, I really hope so. Of course, pending funding. But, we have a tremendous responsibility here. We know, from work including Catherine Monk's, that the developmental origins of health and disease and what happens, both in utero and those very early periods, can lead to effects, long-term effects that don't show up until, much later. So, for example, flu exposure in utero is associated with increased risk of schizophrenia. And we're not going to know that for another 20 years or so, if this particular virus might increase the risk of schizophrenia. So we really have, a responsibility here, given this incredibly rare cohort. We're never going to be able to generate this kind of cohort again with deep phenotyped exposures, as well as deep phenotype maternal stress. And so we do hope to continue. But I will also say we're not going to wait 20 years for the next outcome. The power of this work has been actually even more important tangentially, and sort of how it's come together as a big initiative, as a big collaborative. And Ira will put on a slide which will be extraordinarily busy. You are not meant to understand what's going on, in each one of those little wheels on the spokes on the wheel, but just to kind of show you a map of all the different collaborations that we've, been enabled so far with this cohort. We've now enrolled over 2,000 families into this cohort, many of who stay with us longitudinally and generate data, year after year. And we've had really surprising collaborations. So Dr. Anil Lalwani, an ENT doc who studies child hearing, came to us and said, many viruses, in utero exposures to many viruses, cause hearing loss. So can we look at this question in combo? And we had the data, and Dr. Lalwani just published a beautiful paper showing that there was no increased risk We had another ENT who studies mom smell, who was interested in knowing if the smell of moms was affected long-term if she had COVID during pregnancy. And indeed, he just published his paper, Dr. Jonathan Overdevest, showing that there are unfortunately long-term effects. So, you know, we've enabled these very surprising sometimes collaborations. But for me personally, what this cohort has enabled is to study early relational health, which is the primary focus of my own lab, and to show you the power of having such a large cohort and with so much deep phenotype early relational health. Because I was, you know, I started this cohort. Of course, and early relational health is my interest. You know, we put a lot of different measures of early relational health from the beginning. And so I'm going to hand it over to Dr. Andriane Lavallee from the center, who will tell us a little bit about what we're finding. And she comes at this from a really unique lens of being a former NICU nurse.
Oh, yes. I hope you guys can hear me okay. Thank you, Dani, and hi, everyone. So my piece of this work is more broadly speaking, focused on understanding how those early relationships between parents and infant, or what Dani just referred to as early relational health, shapes infant social learning and social development. Early relational health is a word we use. It's a very large umbrella term that we use to describe the many different facets that describe this relationship that forms between parent and child. So I'm sure you've heard some of these concepts like bonding, emotional availability, or maternal sensitivity, which are unidirectional and describe how moms are feeling and behaving with their babies. There's other unidirectional concepts, like I'm sure you've heard of attachment, that in this case describes how children relate to their caregivers in stressful situations. And there's other newer concepts like emotional connection that are bidirectional, which means that they really describe the essence of what is going on in between the mom and the baby, which we've referred to as the mother-baby dyad. And we care about early relational health because we know it predicts better child outcomes later on. And I'm just going to very quickly go over a couple examples, but when we study these different concepts individually, other studies have shown that, for example, bonding predicts better socio-emotional skills later on in these children. So the sensitivity predicts better socio-emotional skills as well, and better language development. Emotional connection predicts fewer behavior problems, and so does attachment, predicts fewer behavior problems and better socio-emotional skills. But as you can sort of see here, is that there's, first of all, a lot of overlap. And more importantly, there's a lack of the precision we have in the understanding of what each of these specific concepts really predict in terms of specific outcomes in those children later on. And that is because all of these concepts really have never been studied together in one single longitudinal cohort of mother-baby dyads. And so in the combo cohort, because we were worried initially that the stress and isolation associated to the pandemic would affect social development, we collected a very rich data set on the mother-child relationship, as well as on child neurodevelopment and social development at several time points throughout infant development. And so what combo gave us is this really unprecedented opportunity to study these many different early relational health facets and see how they each relate to later child outcome in a way that really has never been done before. And so for the rest of my short presentation, I'll focus on three specific concepts that are highlighted in red here. So bonding, sensitivity, as well as emotional connection. And so with these three concepts, the first thing that we really wanted to know is how do they relate to each other? How do they associate to each other? And before I show you some of our own data, I just want to quickly illustrate that if these concepts were all the same thing, so measuring the same aspect of the relationship, we'd see the data looking like something like this. We'd see a perfect association. If they were moderately associated to each other, we would see something that would look like that. However, what we found was at first surprising to us. We actually found that there was absolutely no association between, so on the left of the screen, you see emotional connection and maternal sensitivity, both measured in the same mother-baby dyads at 4 months. So no association there. And same for but bonding and emotional connection, no association there. And now this is just gonna switch. And finally, between bonding and maternal sensitivity, we see a flat line again, no association here one more time. So what we sort of previously had a theoretical understanding of, we now have the data that really shows us that these are different measures looking at different aspect of the distinct facet of the parent-child relationship. And so with that in mind, the next thing we wanted to look into is start teasing apart what each of these different concepts measured in the first 4 months of life then predict in terms of child neurodevelopmental outcomes almost 2 years later. And so what we found is that bonding measured at 4 months actually predicts externalizing symptoms at 2 years of age, which are what you can think of ADHD or impulsivity or aggressive behaviors. And we also found that emotional connection predicts cognitive development and fine motor skills, but very importantly, gross motor skills, like running and jumping, expressive language, which refers to the child's ability to use language to communicate, as well as receptive language, which is this child's ability to understand spoken language and words. So this was, of course, really important to us, but it's important if we care about particularly outcomes, like, for example, school readiness. If we want to promote these outcomes at 2 years of age or even more closer to school age, it's important to understand what impacts the developmental building blocks in order to promote these outcomes and make recommendations that are evidence-based.
Thank you so much, Andrea. And again, my pediatrician brain is like going, 10 miles an hour thinking about all the potential here, to intervene, really, at the end of the day, to intervene and to help. I am wondering though, Dani, if we're talking about bonding, sensitivity, emotional connection, as constructs that predict different things, what does that mean for specific interventions, right? Which is what we're talking about.
Right. No, that means that we have to get that precise in our interventions, right? So, this is the very first time that we're beginning to untangle how these constructs come together to form the full picture of early relational health, right? We've been talking about early relational health for the last few years since the AAP, or American Academy of Pediatrics, put out a policy statement in the summer of 2021. But the precision to which we need to get to, we're just beginning to scratch the surface. And it's important because the ultimate vision here is the promotion in pediatric primary care.
Of course.
So what are we going to promote, right? So we need this data, we need the specific outcomes and how they're linked to the specific constructs and how they're linked to the specific outcomes. And that then we need to develop interventions that are, very specific to what might be needed in that family. So the vision here is strength-based promotion of things that are noticed to be strong in a family, and also interventions, light touch interventions that nudge that family in the right direction for other constructs where they might not be so strong. And that's, really, that's why it's really important to get precise.
Yeah. And I'm, also thinking there's so much going on in these early months and years, I would say, of life, right? So how can we tease apart all these different things, and how do we make sure that the effects that you're seeing are due to or explained by this early relational health, right? This construct of early relationships, and not just correlations.
Right, right. you're describing the complexity of this data, right? You know, it's when you're studying relationships, it's important that the relationships are strong between people, but it's also really important to have relational data, right?
Yeah.
So it sounds trivial, but dyadic data is really complicated. So, you know, having data on just moms and having data on just babies is much easier. Once you have those two together, it is really hard to integrate. This is actually a big problem. Then you add on that layer, the longitudinal aspect. Then you add on that layer, the complexity of the multidimensionality of this data set, right? So it becomes a really hard problem. And then you layer on top of that the fact that we are actively trying to increase the velocity of this research, right? That we have so many collaborators. How do we get data out to them as quickly as we can? And so I will now hand it over to Dr. Paul Curtin, who recently joined the center to lead a new state-of-the-art data core.
Well, thank you, Dani. I appreciate that. And yeah, I hope I'm sharing my screen now. So today I'm going to speak to two missions I'm happy to lead at the Center for Early Relational Health. The first focuses on my work as director of the center's data core, where we're establishing a first-of-its-kind database built to advance dyadic research and early relational health. And this sort of initiative started with the difficult reality that Dani was getting to, that in focusing on the connection between mothers and children, we encounter a number of challenges. So in particular, while there's a wealth of data on mothers and there's an abundance of data on infants, these data are typically isolated, siloed, and disconnected from one another. So one might have research data of a given child in hand, only to find the maternal data you want to connect with is locked away in a different repository. And that could bring on, you know, a 6 to 9 month delay to clear all the data processing and regulatory and other hurdles involved in connecting and linking these data. We founded the data center to solve these problems by integrating maternal and pediatric data at a foundational fundamental level. So the state-of-the-art data infrastructure that we're developing will connect these isolated silos, harmonize and sanitize the data, and ensure they're connected, accessible, and safe to share with our collaborators in the future moving forward. In a nutshell, what we're trying to accomplish is to take those 6 to 9 month delays of data amalgamation and processing that we're faced with when we started this field, and make this a 30-second query for our collaborators in the future. And that's what we're focusing on here. I also want to speak to you about another major focus of the Center for Early Relational Health's data core, and that's in computational methods development. So we've recently founded the Panda Lab, where we develop and apply new computational tools to better understand children's health. You've heard today from our speakers, they've emphasized our focus on early life as a window into the developmental origins of health and disease throughout the lifespan. And an implicit sort of fundamental problem we face in this field, and what we hope to solve, is that the nature of cause and effect is rarely simple, rarely instant, and rarely obvious. Meaning, in practice, that we often find that an experience in early life can exert a big effect on development. But those results don't become apparent until the infant has become a child, an adolescent, or an adult. And this is essentially the problem sometimes called a butterfly effect, where small changes experienced early can result in vastly different outcomes later on. And at Right, I highlight this through the Lorenz attractor, a tool developed in the origins of chaos theory, which provided a platform to study these effects and which we often leverage in our predictive work. So to capture these sort of relationships and dynamics, our lab integrates methods from a diverse array of fields, including chaos theory, probability and statistics, econometrics, and others. We use these approaches to understand how information is moving and changing in a given system, for example, a child's brain and behavior, and how that system connects with others, for example, their parents and other children. This figure illustrates the notion of connecting two complex, chaotic systems that may be lagged in time. And we do this towards the goal of better understanding our own development, but also for the practical benefit of developing better predictive models and warning systems to tell us when kids may benefit from an early intervention or environmental adjustment. Our group has patented multiple machine learning technologies for these goals, and we aim to extend these frameworks, in particular, to link early relational health to later neurodevelopmental outcomes. And I'd like to offer a brief example of how this can work. With my colleague at the center, Dr. Christine Austin, who you'll meet soon, we developed a method to characterize a broad array of biomarkers experienced in early life, including micronutrients and toxicants that are taken during the prenatal and perinatal period. We built a machine learning platform that leveraged these data to predictively distinguish between children that developed in a neurotypical fashion from those that developed autism, ADHD, and comorbidity for both conditions. Our emphasis on the immediate early life in the prenatal period allowed us to see 4 years into the kid's future and identify which kids might need a little extra help early on. So this emphasizes the importance of capturing these butterfly effects that we're interested in and where we focus, and that our center really focuses on. If we can detect these signals early, we can intervene while the system remains plastic, remains malleable, remains moldable. The infrastructure and the methods that we're building to achieve this will allow us to study early relational health and its impacts across the lifespan with the same efficacy and the same specificity that we've been examining chemical and biological exposures. And I think that's an exciting opportunity that I don't think you could really pursue in any other kind of cohort without the really profoundly deep phenotyping that was established during COVID. And so I'll leave it at that for now. And thank you for your time and turn it back to Dani.
Thank you so much, Paul. Fascinating work. Of course, it makes sense that removing barriers, right, these silos between babies' data and mom's data, just get you better science, better results. I do wonder, Dani, as we keep thinking about surveys, right? I think, parents these days just feel so judged from so many angles, right? From their doctors, from the media, from the expectations that are, endless sometimes. How do those surveys, right, that are important in your research relate to this more objective data, like tissue samples that Paul briefly mentioned?
Right. So, the quick answer is they don't tend to relate too much. Subjective and objective, as I briefly touched on before, are complementary measures. They measure different things. The subjective piece or the psychology of it is really good at sort of pointing us in the right direction of what matters, right? But it's really the objective data and those tissue samples that get to the policy level changes that we're ultimately hoping to get to, right? And I'll give you a few examples. So loneliness feels bad, right? Like, of course, you don't have to try to convince people. But it wasn't until we discovered there was a large study that showed that it actually cuts life short the same amount as smoking half a pack a day. The governments got together and said, okay, we need to do something about it.
Right.
Doulas. Moms said all along, we love doulas.
Yeah.
They're great for us, right? But it wasn't until there was objective data of better outcomes for both mom and baby that insurances started paying for it.
Yep.
Right?
I believe it.
Adverse childhood experiences, or ACEs that we all talk about it. They've been around in policies for many, many years, right? Why? Because we have objective measures of things that are happening in the brain, things that are happening epigenetically, life course outcomes, including increased risk of mental health problems and diabetes, right? So we do need that objective, hard biological data. And so I'll hand it over to our last speaker, Dr. Christine Austin, who is an analytical chemist, really at the forefront of these kinds of tools. And we'll talk a little bit about her development of these kinds of tools.
Thank you so much, Dani. Hopefully you can see my slides now. So as Dani and Catherine had mentioned earlier, inflammation is an important factor in the developmental origins of health and disease. exactly when inflammation occurs, so whether it's in the second trimester, third trimester, or much later, is particularly important because depending on that timing, neurodevelopment can be nudged in a different direction. Or in relation to what Paul was presenting earlier, it's when that butterfly flaps its wings that is just as important. Now, to capture that timing, we would need to collect hundreds of blood samples over many years, and that's just not feasible. Not only would it be incredibly invasive, stressful, and costly, there's no way we could collect multiple samples directly from a fetus. So one solution to these problems is analyzing tissues that grow in a way that actually archives biological information over time. Now, teeth, they're basically like little time capsules that have been recording your biological life since you were in the womb. So baby teeth begin forming during the second trimester and follow a growth pattern such that a new mineral layer is formed every day, like growth rings in a tree. So as the tooth is growing, chemicals and proteins that are circulating in your blood become trapped in that mineral layer and are preserved. We can use lasers and other techniques to precisely sample along those growth rings and reconstruct a biological history from the second trimester up until that tooth falls out naturally in childhood. In combo, children are about to lose their first tooth, and we will be able to retrospectively measure prenatal and infant biological information with an accuracy as if we had been collecting daily blood samples for years. We hope to be able to use this information to develop a biomarker of early relational health. So to really drive home the importance of biomarkers, here I'm showing lead exposure histories of two pairs of genetically identical twins. So on the left, you can see that the exposure profiles between the two twins is very similar. Whereas on the right, you can see there's quite a large difference, especially here after birth, between each twin in this pair. Now, these differences cannot be captured by questionnaire data, and these differences were in fact associated with a difference in neurodevelopmental outcome at 4 years of age. We've also done this type of study in other cohorts where we've actually found that early metal exposure is associated with neurodevelopment outcomes that we then measure 50 years after exposure, so well into adulthood. We've also developed biomarkers of infant diet or breastfeeding in teeth. Now, these markers are collected at a much higher resolution than can be possible with questionnaires, and they avoid recall errors that we're all subject to. We can use these markers to study the impact of breastfeeding on early relational health or as a factor of the developmental origins of health and disease. We've actually even used this technique to go all the way back tens of thousands of years to study breastfeeding in a Neanderthal tooth. Now, previous studies on inflammation, especially prenatal inflammation, have only been able to estimate the fetal inflammation from the mother's perspective, either from collecting maternal blood samples or maternal medical records. Using teeth, myself and colleagues Dani Dumitriu and Paul Curtin, we were actually able to develop the very first method to directly measure prenatal inflammation directly in the fetus. So our study even showed that inflammation specifically in the third trimester was associated with a greater neurodevelopment risk in childhood. Now, here I'm showing you maps of a biomarker of inflammation in teeth from 4 different individuals. The white areas, they represent moments of higher inflammation. And if you recall, because the way teeth grow, we can actually get a sense of timing. We can use these maps to measure not just the intensity of inflammation, but also its duration and when it occurred. So as you can also see, these 4 individuals show very different profiles. So this individual first here on the left, generally pretty low inflammation. They had one sort of major intense event that was a very short duration just here after birth. The second individual had many more inflammation events, but seemed to be occurring almost every month and were generally short duration. The two final individuals on the right, you can see have a much more chaotic inflammation profile. They have both quite long duration events, acute duration events, and these are occurring at a very different frequency and very different intensity over time. All of this information would be completely lost from a single blood measure or from a retrospective questionnaire. Many of these events may even be asymptomatic and go unnoticed by a parent or doctor. In combo, we have an unprecedented data set, and by measuring as many biological signals as we can further expand this resource even further and study early relational health more deeply, which will then inform policy and intervention strategies with objective evidence that's needed so that these can be effectively targeted and implemented at the right time. I'll turn back over to Dani now.
Thank you, Christine. I, full disclosure, had not seen your slides before we got together, and I'm just sort of like going closer to the computer, like, no way, such exciting data. I mean, it seems, of course, just hearing it like a really big deal, but I want to make sure that I am interpreting it correctly. So what Christine, your team is telling us is that we may soon get objective data that allows us to match the timing of inflammation in utero with the timing of the COVID-19 infection in utero and get even more precise in how we predict some of these outcomes.
Absolutely, absolutely. And not just inflammation, but many, many other things, and with, time-stamped precision. But that's not the exciting part here, right? Even though that's pretty exciting. So I do want to double click on the fact that, as Christine mentioned, this piece of research that we did together while we were trainees together, actually is the very first time that we're measuring inflammation in a fetus, right? We've only measured it in mom during pregnancy from blood samples, for example. But what's really exciting here, and what Christine, Paul, and I will be working on, is the first biomarker of early relational health.
Wow.
We do not have that.
Wow.
And we need that in order to drive policy changes. We need that hard biological evidence in order to drive organizations like the AAP towards those policies that will nudge neurodevelopment towards strength-based promotion and increased resilience.
Yeah, such incredible stuff. I have learned so much listening to you and your team. I'm sure people that are watching have a lot of questions, so we'll pass it back to Ira.
Wow. Yes, I'm with you, Edith. I feel like we've heard quite a bit, and I feel like in the cartoons, like when there's a light bulb above your head, and you're like, oh, that's really interesting. And I also sometimes feel like maybe the question mark or the little cloud where I'm like still confused. And so I assume many of the funders who are with us on the call might be thinking the same. So I encourage you to share in the chat any of your aha observations, as I'm calling them, or if you have any questions in the chat, that would be helpful to get to. But as I think about sort of some of the light bulbs or the things that are sticking with me as I almost like work my way backwards through the last hour, like this concept of teeth as trees and this idea of teeth like being able to be a substitute for like having to like give a blood sample every week or every month is just such a powerful image for me about how that might change the knowledge that we could have around early relational health. And it's also reminding me about how Catherine talked at the beginning about how early relational health begins before birth. Well, the teeth that Christine's saying, and the teeth are there before birth. So guess what? We could actually understand some of what's happening there. So that's just one of the things that was sticking out to me. A through line from all the different slides that you were sharing are about relationships. At the heart of this is the relationships between the parents and babies, but the relationships on that big chart that was a little hard to read with all the different people studying all the different things. And so this comes down to things like smell or hearing or other parts of the body. We're going to really start to understand that. And then the way that Paul has created the data set will allow us to think about relational data. And so I don't know that I had fully processed previously about how so much of the data we have around early relational health is really from one direction or the other. It's about the parents' markers, or it's about what's happening in the baby, and being able to capture all of that and map it together, I think will be really powerful. And it's a good thing that we can do all that, because it's not the first time I've seen those graphs, but every time I see those graphs that Andrian showed, and these lines look like flat line roads in the plains of middle America, right? There is not that angle that we were expecting. And I think that when I've been at this work for over a decade, and Dani, you talked about, we're almost 4 or 5 years in now from the AAP statement on early relational health. And I think at the time, everyone was saying early relational health. Oh, you mean attachment? Oh, you mean bonding? Oh, I know all about that. They're all the same thing. Those charts are like that. I think we might want to dig into that in a moment. But I want to take us all the way back to where we started and what I think drew a lot of people to come today, which was our interest around this pandemic period, and what that I think intuitively we all said, oh my gosh, I lived through that. That did not feel normal to me. And so what must that have been like for the people who gave birth, Edith and others, who gave birth at that time? And we've got several people in the chat saying, I'm here professionally, but I'm also here personally, because I too gave birth during the pandemic and was wondering what that would all mean. And I think, you talked about, Dani, showing up at that time yourself, like post-Zika, worried about vertical transmission, but you also come to this as a mother. And I'm curious for you as an individual, what were you thinking as you were immersing yourself into all this at the height of the pandemic? And how has that carried you through in the work that you're continuing to do? And then hopefully, my funders are not usually shy, so I appreciate that you were a little bit better about telling your unexpected joys. I hope you also have some questions. If not, I know I will keep some going. But let's start, Dani, with where you were personally at the beginning of this, and what drew you to this, and what you've received through this research.
Yeah. I am a mother. My children were, at the time, I had 2 16-year-olds, so high schoolers, and 1 8-year-old. I often get asked, how did the effects of the pandemic, how were the effects different by different age groups? And, I am by no means the researcher to talk too much about how older children were affected. But I can just talk from my own, personal experience, that the effects of school-age children, and in particular adolescents, were at this very critical developmental time point of needing those social interactions with their peers. They suffered, tremendously. In many ways, I think that the COVID generation, so the generation of babies born during the pandemic that I'm studying, might be actually the luckiest generation of all of the children of the pandemic. Because during those very early years, during those 0 to, especially infancy, the first year of life, the most critical connections are really just with the parents, right? And so the parents were home a little bit more because of the lockdowns, and perhaps over time, and we are actually starting to see this a little bit in our data, that perhaps over time they actually got to spend more time with their parents, and got to have perhaps slightly improved early relational health than those older children who were experiencing things like school lockdowns.
Speaking about older children, I would love to see or hear from you as you think about, we are 5 years in for those babies who were born right at the beginning of the pandemic, but I know your research, you were enrolling people for at least a year after that. And so some of those people aren't going to be 5 years old for a while. And then, of course, you have to analyze the data. But as we get to thinking about what does the pandemic mean for these babies and the families when their kids are 5 years into this, what are you going to be looking at, and when do you think you might have some of that data to share with us?
Yeah, thank you. So of course, research takes a lot of time. So far, all of our published data has been on children up to 18 months, and we are submitting a couple of papers on 24-month outcomes. But so it takes time, at least a 3-year lag is to be expected. But there are so many more things that we are interested in studying just from the COVID perspective. So right now, these children are entering school age, and we are beginning to look at things like school readiness. We're beginning to look at things like internalizing and externalizing behavior. So externalizing, thinking about things like ADHD and diagnoses of ADHD, internalizing, thinking about things like anxiety. So those are going to be some of the next steps that we look at. Then during their adolescence, we will worry about actual anxiety and depression disorders. As I mentioned before, when they enter their 20s, we will have to evaluate schizophrenia risk. So there are many, many things to still think about. There's of course also physical health outcomes. So we have a team looking at wheezing. We also are interested in perhaps any metabolic changes that might happen. So might there be an increased risk of things like diabetes down the road. So there are many, many things to still evaluate, just in that original combo cohort that was specifically enrolled to study COVID effects.
And one of our attendees was also noting around this interest around the child's 5th birthday, because they're seeing that in some of their ASQs that are already showing up, that they're seeing already some challenges. They're hearing about it from early childhood program teachers and others about challenging behaviors. So it'll be interesting when you do have the data to be able to see, is that showing up, or is this, just incidences that people are seeing in their community? But what does it mean from a larger data sample? I'm going to bring in our other speakers, just so that way, as we bring in some of the other questions, I'm going to spotlight them as well. So that way, if they want to respond to the questions, they can do so. So I think I've got everybody here in our little mini Brady bunch, not a full Brady bunch, but a good group. So I want to lift up Lauren's question, where she says, could you say more about what the process would actually look like to distinguish a biomarker that's unique to early relational health and not picking up other effects? And maybe this is where all those cool things that Paul was showing us graphically come in, but catch us up a little bit, Paul. Yeah.
Yeah. So this is actually a problem, really neat opportunity created in combo that doesn't necessarily come from some high fancy technology, but it comes from just really nice study design. So the way combo was designed and initiated combined several cohorts, but primarily local to New York. And more recently, with support, they've expanded to recruit a new cohort nationally. Now, from the perspective of biomarker development, this is exactly the scenario you want, because what you want to do is create a test or design an algorithm or some other means of linking a biomarker to an endpoint. That's only step one. Step two, the step that actually matters, is generalizing it to new people, showing that this is not some quirk of your data set that works on a quirky New York population. It's something that generalizes to human beings. And so, yes, there's a lot of fancy, algorithms and blah, blah, blah. We don't even have to go into it. What really matters is the hard work of putting together these thousands of people locally that creates a data repository for folks like me, and then doing the ongoing work of gathering new people that we can generalize to. And it's that generalization that matters, right? That's where we'll know if the biomarker works or not, when we can deploy it and measure its accuracy in people that were recruited entirely independent of this manner in which it was trained. Does that make sense?
That helps a lot. Yeah. And so maybe I want to, I know, Dani, I'd love to hear a little bit more about what Paul's describing here. I know a little bit, but I know most of the people here are a little less familiar with sort of where are we going, right? We've looked back at data for families that you recruited back in 2020, but Paul's now describing and saying, well, looking forward, we've got to have a broader sample. Tell us about some of the new research that's underway and where you're headed.
Yeah. So very sadly, we closed enrollment in the combo cohort in the beginning of April. 2025. We did enroll over 2,000, I think it's 2,054, which was an impressive amount. But very happily, literally the next day, we started the enrollment in the combo national effort that Paul briefly mentioned. So this is now an effort that is in collaboration with Reach Out and Read, Reach Out and Read National. We are in a pilot phase right now in 6 different sites across 6 different states. And this cohort is really specifically designed for looking at early relational health outcomes. So it does have the backbone of combo, but we have added even more measures of early relationships and even more deep phenotyping of each individual relationship. Also expanded outside of moms to include other caregivers. We are trying to recruit up to 5 caregivers per child. And ultimate goal of this is to grow into a national cohort that really focuses on the 0 to 3 relationships, and then later maps out the child outcomes.
I was just like sort of thinking, already about the many things that were like in Paul's crazy little data set. And then when you said 5 different relationships, I was trying to then imagine all the different charts that Andrian then might be able to show in the future. And I do want to come back to those just because I know we still have a couple more minutes, because I do feel like that's a place I want to spend a little bit more time, which is those flat lines. Do you have, I know you've got to do more research to better understand why, but I think I found it very surprising. And I think even you guys were surprised that like they were very flat. What questions, scientific questions, does that raise for you of like where you'd want to keep studying around this to better understand what could possibly be different there? And then if we did get answers to that, how does that help us with the biomarkers that Paul was talking about?
First of all, we were extremely surprised. we didn't think it was going to be a perfect correlation, that first type of graph that Andrian generated, but we did think there was going to be some sort of association between things like maternal sensitivity and emotional connection. But I think that this is also highlighting why, despite the fact that we do have an AAP policy statement now to that actually urges pediatricians to focus on early relational health in their clinics, we don't have a means to do it. And our data highlights, part of the scratches the surface for why we don't have a means, which is that we don't have the precision to understand what early relational health is. We are beginning to build that precision, build a taxonomy, right? What are the components and how does each component map onto long-term outcomes? And once you understand that map, then you can start actually intervening in a very precise way that is meaningful to a particular family.
Lots of work still to be done, but it's also amazing to think about a period of time where the idea of having even 10 funders come to a conversation about early relational health. And now we're at a place that we had nearly 100 people register for this event. So there's just like real great interest in this work. And I think it also shows how ready we are as the field to say, like there's interest around early relational health. And now we really want to unpack it and actually really get to the bottom to say, how are these different constructs different? How might we figure out what that biomarker could look like? The comment in the chat from an actual pediatrician who advises one of the foundations, said, no question yet, still in awe, right? And so I think that is a great place for us to be because it's beautiful that the research is bringing that awe. I think all of us who have experienced the parent-child relationship understand the awe that is present in the relationship itself and wanting to figure that out scientifically, right? We all feel it in our gut, the amazing awe and power of what that relationship could look like. But as you said, Dani, we also know what loneliness felt like, and we knew that was bad. But until we could actually show these real health effects, right? And folks in palliative care have shared with me, they were like, it was all about quality of life, and everyone said we should do that for quality of life. It was only when they showed that palliative care extended life that everyone actually started paying attention to it. So it's amazingly powerful what you've all described today, how prenatally through this and following people for a long time, we're going to get the data, we're going to get the precision that's going to help us really figure out how to continue to support families in doing what they're already doing well, and help give them those little nudges in the course of a short pediatric visit that can help move them in the direction to help address areas of early relational health where we could have some real impact. So I just want to thank our speakers today, Edith, Dani, Chris, Andrian, Paul, Catherine, all of you, like just everyone. Thank you so much for this amazing work that you're doing. The way you all collaborate with one another does really feel like you're all part of that one big circle. And for the joy that you've brought to us today and really better understanding this work and knowing that there are great people continuing that work. I want to thank the funders for joining today, reminding you that you're all now part of the Early Relational Health funders community. So I hope you look forward to an email tomorrow where you'll get a copy of the recording and all of the other links and everything that you might need. And I hope you find some more unexpected joy in the days to come. Thanks so much for joining.